Hello and a very good afternoon to all our viewers. Welcome to a brand new session here with our expert. Today's topic of discussion is prenatal screening and testing, understanding the genetics. So for this, we have with us a renowned gynecologist, Dr. Sanjay Gupte. Welcome, sir.
Thank you.
He's the medical director, consultant OBGYN at the Gupte Hospital and Clinic, and also the director of the Green Array Genomic Research Solutions in Pune. He's an eminent gynecologist with over 4 decades of clinical experience. In addition to that, Dr. Gupte is also offering medical legal consultations for the past 15-20 years, free of cost. Due to his passion for teaching, Dr. Gupte has established Gupte Hospital in Pune, in Maharashtra, as an excellent teaching center to train medical practitioners in the field of obstetrics and gynecology. And under his leadership, Dr. Gupte Hospital is also serving as a center for research in reproduction and NABH accredited single specialty model healthcare delivery system. Additionally, Dr. Gupte has published several articles in both national and international journals and has written many books. It is an absolute pleasure to have you with us here, sir. And over to you.
Thank you, Dr. Darshika, for that very good introduction. And now with that, let's directly come to the topic of today, which is very interesting because this is a newer field that is opening up to all of us, especially in our faculty of gynec and obstetrics, and also in overall in a healthcare faculty. The atom was the discovery of 19th century, which changed the world, and might revolutionize the 20th century. And the base is the molecule of 21st century. So that what I mean by that is the base, the nucleotide bases are going to change the 21st century like the atom and bite did in earlier century. In 1988, Human Genome Project was set up in US, and finally in year 2000, full human genome sequencing was achieved. This project required $5 billion, 30,000 computers worldwide, years of hard work by scientists across the world. All the 20,000 plus genes in human genome and its 3 billion base pairs are now mapped and are available on the internet for comparison and research to any of us. The science of this genomics has progressed so fast that now one may get full genome sequence done at the cost of $1,000 in 2 days' time. So just imagine if the automobile science would have progressed like this, we would have got a Mercedes made every 1 hour and would have cost hardly 50 cents. So aren't you surprised? Right. So let's look at this genomic medicine. The largest human impacts of the genomic technologies are currently seen within the healthcare sector, be it personalized medicine, rare disease research, population genomics, so on. The healthcare applications of genomics are also greatly influencing the development of genomic infrastructure world over that we have seen during the recent pandemic. This infrastructure will allow other genomic applications beyond health to develop also. So genetics can help us find cause of diseases, mechanism of disease, and sometimes response to the therapy also. Genetic issues are not uncommon. One feels that, oh, this is something not really in common, seen in common clinical practice. In fact, 2 to 3% children are born with congenital birth defects, and by age of 18, approximately 8% are discovered to have one or more anomalies which were not diagnosed before. And two-thirds, that is 67% of the population will experience a disease with a genetic component in their lifetime. And if we include the cancer or onco problems in this, there will be almost 91%. So the genetics and genomics is there with us all the time. What are the fields and clinical practices where genomics, you take anything from preconception to newborn, PCOS to fertility, then the NCDs, diabetes, the cardiovascular problems, what have you, cancers, right from diagnosis and treatment, and various other disorders. What do we see in clinical practice? And as far as genetics is concerned, we see all different kind of anomalies and the disorders in day-to-day practice. Chromosomal disorders form about 5 to 7%. Single gene disorders form about 1%, and multi-gene disorders 2 to 3%. While multifactorial disorders, that is polygenic plus exogenous factors, are 40 to 45%. Somatic cell disorders are, that is mainly cancers, about 10 to 15%. So let's look at all these one by one. Chromosomal disorders are numerical and structural, for example, aneuploidies and translocations. Duplications or deletion of chromosome or part of it can be associated with severe outcomes like mental retardation, minor or major structural anomalies. We know about the Down syndrome and so on, which are now a common knowledge. Single gene disorders are caused by mutation in single gene. More than 6,000 monogenic disorders are now identified. Single gene disorders show Mendelian inheritance, autosomal dominant, like achondroplasia, polycystic kidney disease, Huntington's chorea, and there are autosomal recessive also, like albinism, cystic fibrosis, congenital deafness, and beta thalassemia. There are again sex chromosome linked, like X-linked and Y-linked genes, and for example, color blindness and hemophilia that we know about. Then there are, of course, multi-gene disorders, and these are familial hypertrophic cardiomyopathy. We see many times, sudden death in a young patient, which could be because of such issues. Various thalassemias, Alzheimer's disease, epilepsy, preterm labor, and so on. Then, of course, every day we face disorders like diabetes, obesity, hypertensive disease, cardiovascular disease, and we need to know that these are also genetically multifactorial disorders, and genetics becomes very important in these disorders also. So there are a number of tests now that we can do for finding out and go to the bottom of the cause of all these disorders. Karyotyping, microarray, Sanger sequencing, next generation sequencing are the tests which are comparatively frequently used, while FISH, spectral karyotype, linkage analysis, GWAS, complementary DNA, RT and QF-PCR, Southern blot, and MLPA are other available tests. We'll discuss some of them as we go along and discuss some of the cases also as we come across. So let's start with simple thing. What is a karyotype? We know it is a systematized arrangement of chromosome pairs in descending order of size. It is used to analyze the number of structure of all the chromosomes, and it provides only a low resolution screen for chromosomal abnormalities. Chromosomal microarray, on the other hand, this CMA test, they looks for duplicated or deleted chromosomal segment, sometimes called copy number variants. They include microdeletions and microduplications of chromosome segments. So these are, small deletions or small duplications, which are too small to see under a microscope, but may contain multiple genes at the same time, and so important to diagnose separately. Most abnormalities of chromosome number, trisomy, monosomy, including Down syndrome, can be diagnosed, and most unbalanced rearrangements of chromosome structure can be identified by microarray testing. Ideal, this especially chromosome microarray in practice is ideal for product of conception testing, because even in conditions like missed abortions, where you don't find, you can't get karyotyping because there are not live cells available for culturing, one can still do chromosomal microarray and find out the cause, what was wrong with that concept test. So let's come to a very important screenings, and that are called as non-invasive prenatal screenings. So what is this prenatal screening? Prenatal testing offered to women during pregnancy to determine if the fetus has possibility to be born with a genetic condition or birth defect. The purpose of prenatal screening is to identify any potential problems that may affect the health of the baby or the mother during pregnancy. And the types of prenatal screenings are like ultrasound, blood tests, and genetic testing. What we are interested today in, of course, is in genetic testing. So, what are the guidelines for prenatal screening? They vary depending on the country and the healthcare system. But there are some common screening tests that are recommended by many healthcare organizations worldwide. And these include first trimester screening, second trimester screening, carrier screening, and now non-invasive prenatal testing, and of course, diagnostic testing. There are several advantages of prenatal screening. They include early detection of potential health problems, then depending on that, informed decision making, reduction of anxiety, improved pregnancy management, and improved outcomes. What is non-invasive prenatal screening then? Non-invasive prenatal screening, or NIPS, is a type of prenatal testing that uses a blood sample from the mother to screen for certain chromosomal abnormalities in the developing fetus. NIPS is also referred to as cell-free fetal DNA testing, as it analyzes fragments of the fetal DNA that are present in the mother's bloodstream. For example, as we can see in this particular figure, NIPT is a prenatal screening test, that can be performed beginning of around 10th week of pregnancy. Ideally is about 11th and 12th week, because then we get a good amount of DNA. Small fragments of cell-free DNA from the placenta enter the mother's bloodstream, and these cell-free DNA samples of the mother's blood are analyzed for evidence of extra missing fetal DNA segments. So we do the genetic test on that to find out whether there are any, especially if any anomalies are there. So this is how it works. Risk scores are generated and modified based on biochemical analysis and population statistics. So double marker, or previously triple markers used to be done, and then one decides whether to go ahead with NIPT, CVS, or amnio. Nowadays, in most of the countries, including now the NIPT as a direct test, or first choice test is going on, and especially in ACOG and in United Kingdom, NIPT is done as a primary test. So clinical indications when to use a first line test: any pregnant woman above 10 weeks of pregnancy, women with advanced maternal age, ultrasound and serum screening showing abnormality, prior pregnancy with Down syndrome, other aneuploidies, and in parents with balanced translocation. So all these situations, this test can be used as a first line test also. The sensitivity of this test is very high. As you can see in trisomy 21, 18, 13, it is as good as in almost 99+%. Even in monosomy X, it's 99%. So all these conditions can be diagnosed very correctly and with good sensitivity and specificity in the patient, and that's why these tests have now become quite dependable. Advantages of these tests are they're non-invasive, they have a high accuracy, they allow us early detection, and there is a reduced need for invasive testing. But there are disadvantages also, because they will tell you about the chromosomes, but not about subchromosomal or genetic single gene disorders. There can rarely be false positives, because this cell-free DNA can be from the placenta and not necessarily always. So especially in mosaic situations, sometimes rarely they can be misleading, and of course availability is still limited, especially in our country. Costs are coming down, but also costs are to be taken into account in as far as these tests are concerned. Then, when they are not recommended, if there are already fetal anomalies seen on ultrasound, not pertaining to common trisomies, then these tests may not be useful. If there are multiple pregnancies, not twins, but more than 2 fetuses, then they cannot be validated. And we have to guard against sometimes the vanishing twins situation, when initially there is twin pregnancy, but then it is automatically spontaneously reduced to single. There the test can go wrong or come false positive, and known genetic anomalies that cannot be diagnosed by NIPS. So let's look at a case, 37-year female, first pregnancy, ultrasound at 12 weeks, which was normal, advised NIPS due to advanced age. She was high risk for trisomy 21, confirmed by PCR on amniotic fluid, and microarray on abortus fetal sample, as well as we showed that gain of an additional copy of chromosome 21 at position 511.2, representing a complete gain of chromosome 21. Now it was a trisomy 21. So very correctly and easily diagnosed in this situation, as we can see here. And so NIPS is highly sensitive to detect chromosomal aneuploidies at early weeks of gestation, and that's a big advantage of this test. So in summary of NIPS, one would say it is important tool that can be helped to ensure the health and well-being of both mother and the developing fetus. But we have to remember that this is a screening test and not a diagnostic test, because finally there is, whenever there are chances of the sensitivity and specificity is not 100%, then we have to call it as a screening test and not a final diagnostics test. So let's look at the other genetic tests that are available day by day now. So let's look at CMS, this chromosomal microarray in prenatal diagnosis. We have already seen that it's useful in product of conception situations. But before that, let's again look at what do we mean by this chromosomal microarray analysis. It's increasingly being utilized in prenatal diagnosis due to its improved detection rate of clinically significant chromosomal abnormalities compared with karyotyping. High-resolution single nucleotide polymorphisms, or what are called as SNPs, based microarrays can detect a variety of chromosomal abnormalities, including whole chromosome aneuploidies, unbalanced rearrangements, microdeletions, and microduplications, triploidies, and even uniparental isodisomy and a low level of mosaicism. The ACOG, American College, the SMFM, they have all come out with their guidelines, and these guidelines, sort of provide us when this can be useful. For example, in women above 35 years, fetuses with ultrasound anomalies, fetuses with abnormal result of conventional karyotyping, or fetuses with increased risk of chromosomal abnormality. And whenever unexplained fetal demise is there, when karyotype is showing normality, then these tests can help us in diagnose things further. So indications are, again, advanced maternal age, abnormal ultrasound findings, previous child with a chromosomal abnormality, positive result on prenatal screening test, and family history of chromosomal abnormalities, as well as fetal demise. These tests should be done in all cases of miscarriage, so that we get to know the so-called unexplained miscarriage in patient, especially in repeated pregnancy loss. Preferably CGS microarray and NGS should be done, and this helps in confirming the genetic etiology in many cases of repeated pregnancy loss. CMA as a first line of investigation, should be done whenever when we require a high resolution, when we require to detect micro deletions and micro duplications, and also when we need to detect certain genetic disorders caused by CNVs, and this then has a very high diagnostic yield. The clinical application of results in diagnosis. The result may come as a normal result, it may come as an abnormal result, or it may come as variants of uncertain significance. Because as yet, there are many variations which we may find in this test, that which clearly we cannot say whether they are normal or abnormal variations, because all of us have different variations in our genes, but they are not necessarily clearly abnormal. And that's why sometimes when this VUS or variant of uncertain significance report comes, we need a little training in genetic counseling to find out and interpret this simple test. So in general, the clinical application of results in prenatal diagnosis involves providing appropriate management and counseling to parents based on the results obtained. This may involve monitoring the pregnancy more closely, considering termination of the pregnancy, or preparing for the birth of a child with a genetic disorder. Genetic counseling is an important aspect of prenatal diagnosis, that it can help parents understand the implications of the results and make informed decisions about their pregnancy. Now, common chromosomal disorders that can be screened through CMA, through copy number variants are like Down syndrome, Edwards syndrome, Patau syndrome, Turner syndrome, Klinefelter syndrome, Klein-Duchamp syndrome, DiGeorge syndrome, Williams syndrome, Prader-Willi syndrome. We'll discuss one or two cases of these as we go along. Chromosomal microanalysis and karyotyping are both diagnostic tests used to detect chromosomal abnormalities. However, they differ in their scope and resolution. The karyotyping tensor is advantageous in situation where there is balanced translocation, but in all other situations, microarrays like more detailed sort of a picture or detailed analysis of the situation and tells us about deletions and duplications. So let's look at a case. 34-year-old female reported with an ultrasound abnormality at 17 weeks of gestation, and earlier ultrasounds also showed heart development with a history of poor obstetrics, ultrasound abnormality, cardiovascular abnormalities, thymic hypoplasia or aplasia, intrauterine growth restriction, urinary abnormalities, increased nuchal translucency, thickness, and abnormal amniotic fluid levels. Due to several ultrasonographic abnormalities in the fetal scan and inability to identify syndrome, rule out the chance of missing any other element, chromosomal microarray analysis was performed. And based on her gestational age, the patient was referred for an amniocentesis to determine the reason of ultrasound abnormality. The result was there was a 22q11.2 deletion. All these addresses of the genes we have to usually learn. What it means is there is a deletion in chromosome 22 in Q arm, that is long arm, at loci 11.2. This is linked to the DiGeorge syndrome, or also called as velociofacial syndrome. And this was discovered during microanalysis. The chromosomal microarray assisted in the identification of this syndrome. This result is thought to be rare because only around 8% of such instances are inherited because of both parents are symptomatic. As a result, this CMA analysis assisted this couple in establishing an earlier diagnosis of fetuses, which will aid obstetricians, surgeons, pediatricians, and cardiologists and geneticists in making decisions about the prenatal and postnatal treatment. The second case, 37-year-old female presented with in her 14th week of pregnancy with increased nuchal translucency and a history of recurrent abortions of unclear reasons. She was recommended for chromosomal microarray analysis in the CVS sample due to a family history of heart disease and previous genetic report of her maternal uncle revealed a gain in chromosome 9. She was referred for a serious investigation due to her previous pregnancy history and family history. And what was the result? Distal interstitial deletion of 10 megabytes on 4q. Again, let's not go into the details of the addresses. As I said, eventually one leads to that. But this discovered a congenital heart disease can be associated with this particular problem. And so chromosomal analysis aided in finding a chromosomal defect that could lead to a cardiac disease in the future, which would otherwise be found only later in 19th week of gestation. by an anomaly scan. So definitely allowed an early diagnosis and precise diagnosis at that. So in summary of CMA, prenatal diagnosis, CMA is a highly accurate diagnostic test that can detect a wide range of chromosomal abnormalities, including submicroscopic deletions and duplication. It can also detect some abnormalities that are not visible on karyotyping, such as CNVs. Prenatal CMA may be indicated in cases where there is a high risk of chromosomal abnormalities and developing fetus, including abnormal ultrasound findings, positive screening tests, previous pregnancy with chromosomal abnormality, advanced maternal age, and family history of genetic disorders. The use of CMA as a first line investigation can increase diagnostic yield, improve accuracy, and provide faster results, but appropriate interpretation and genetic counseling are essential. Now let's go into the further details of single gene or whole genome sequencing in prenatal cases. Single gene tests are now they've become indispensable. They in many situations because they can pinpoint to certain conditions like cystic fibrosis, sickle cell anemia testing, Huntington's disease, and so on. Again there are SUG guidelines where these conditions, these tests are to be done, and so American College of Medical Genetics recommends that all women be offered carrier screening for cystic fibrosis and spinal muscular atrophy. In our country, of course, these are not so prevalent, and still the affordability remains a question, and that's why these guidelines cannot be implemented in toto. But I'm sure as the cost of the test drop, we will also be following on this. So benefit of these single release testing is accuracy, early detection, target testing, personalized counseling, and limitations, of course, are as I said, the cost, psychological impact, and sometimes the procedures have to be invasive and so on. So while single gene tests can provide valuable information in prenatal diagnosis, it is important to weigh the benefits and limitations carefully in this situation. So again, let's discuss a case of 15-week pregnant female for first-degree consanguineous couple with no hereditary disease in family. Their prior child was diagnosed with spinal muscular atrophy and died after 2 months. There was no genetic testing done then. Muscles of the back weakened, leading to spinal curvatures. The lower limbs seemed to be affected more than the upper limbs. Breathing and swallowing difficulty was there. Then genetic counseling and genetic test for spinal muscular atrophy was performed on both the mother and father. Both were found to be carriers of SMA, as one copy of the SMA gene was deleted. The patient was informed that their pregnancy had a 25% chance of being affected by SMA, and amniocentesis is recommended to determine whether the fetus is afflicted by this disorder. So the genetic analysis of the amniotic sample was indicated that the fetus is homozygous for spinal muscular atrophy, which is an autosomal recessive condition which requires deletion of both the copies of SMN1. In this case, the fetus is at risk of being affected with this condition. So as a result, this case demonstrates how single gene testing in prenatal diagnosis aided in the screening of the growing fetus to determine possibility of being affected with SMA atrophy like the previous baby, and aided them in making informed decisions regarding the pregnancy. In the second case, again, this case was a non-consanguineous couple. But there was a family history of hearing loss, and the 4-year-old baby and was found to be deaf, and so the female wanted in 10th week to find out whether what's going to happen to the baby. So genetic investigation was thought of. Then the afflicted baby's exome sequences identified a homozygous pathogenic mutation in GZB2 gene, which is linked to congenital hearing loss. And because the female was already pregnant, the prenatal diagnosis was preferred, or couple screening for early diagnosis. Korean villus sampling was done for this gene, And because this is an autosomal recessive disorder, two copies of the genes are necessary for the symptom to manifest, as prenatal diagnosis was suggestive of heterozygous or mutation in GZI. It means that fetus is likely to remain carrier, but asymptomatic for this condition without developing any symptoms. This illustrates how screening of afflicted individuals in the family aided in early diagnosis, and even sometimes it does help in saving the pregnancies, as happened in this particular case. Finally, we come to the most important and the most detailed, the whole exome sequencing in prenatal screening, which helps in genetic variant analysis that may be associated with a variety of conditions and diseases. It guides the clinical decision making, identifying specific cause of those abnormalities that remain unknown, and identifying potential risks and outcomes of their pregnancy for rare and novel mutations. For example, autism spectrum disorder, which is always nowadays a worries of every pregnant couple that we have. Again, there are guidelines when to do these tests. Especially when there are family history, this is important. Then, when CMA has failed to provide a diagnosis, then again this becomes important. But here we have to remember that pre-test counseling and informed consent, because that become the two very important issues, because this we are undertaking a detailed analysis of the whole exome prenatally. So whole exome sequencing, that means sequence of entire coding region, that is exon. The WS can detect mutations in any gene within exome. It is useful in cases of unknown genetic cause, useful in case of disorders with multiple phenotypic representation, but it is expensive. Then clinical exome sequencing means targeted sequencing. That means if we know a sequence which we need to target for detecting that particular anomaly, if we have strong suspicion of that, then we should use that, and that becomes more cost effective as well as faster. So the benefits of exome sequencing are comprehensive analysis, higher diagnostic yields, faster results, and potential for future analysis. While limitations of exome sequences are cost, covers only the protein coding region, difficult to interpret variants of unknown significance. And of course, there are ethical issues. So while exome sequencing can provide valuable information in the prenatal diagnosis, it is important to weigh the benefits and limitations carefully depending on the case. So let's discuss a good case of this particular situation also. 26-year-old pregnant woman presented with ultrasound abnormality at 19 weeks of gestation. The woman and her husband were healthy and non-consanguineous, with no history of infection and or exposure to the teratogens. There was previous history of abortion due to multiple abnormality detected at 24 weeks of gestation. The ultrasound examination of previous fetus was indicative of skeletal dysplasia of the bilateral upper limbs and congenital heart malformations. Suspected disease was Cornelia de Lange syndrome, as can be seen in these accompanying pictures. The short bilateral humerus was there, only the ulna was angled with the humerus. Fetus had congenital cardiac developmental anomalies. Now, the genetic analysis results showed that of course, the pregnancy was terminated at 27 weeks because of fetal malformations. The CMA terminated proband did not detect any chromosomal abnormalities or submicroscopic. So CMA was not useful, and that's why whole exome sequences was referred to the terminal proband and to the healthy parents to assess the risk of recurrence and clarify the potential cause of disease. So WAS identified de novo heterozygous variant. Again, let's not go into the what it was, but in the NIPBL gene, the couple did not opt for their genetic testing at this stage to see if they can they carry mutation, which ideally should be done. Well, she was because of that, she was subjected to amniocentesis after genetic counseling or an extensive genetic investigations for her next pregnancy to see whether the same mutation as in the prior pregnancy was inherited in this fetus. Well, what was found because of several abnormalities discovered in addition to what was reported in the prior pregnancy, this sequencing conducted on amnio sample showed that two novel mutations were discovered. One was in TPM2 gene, and other was like in the previous baby in NIPBL gene. As a result, both the mutations pointed to uncommon genetic illnesses, specifically distal arthrogryposis and Cornelia de Lange syndrome, as shown in the prior account. Hence, in this case, due to multiple abnormalities or possibilities, it was recommended to go for WS to see if there is genetic cause. And so, what it did was, to see it could help in early diagnosis and decision making in this. So whole genome sequences, particularly fetal and parental screening, is shown to be a realistic and successful way of identifying several uncommon illnesses with a genetic etiology, but that cannot be detected by traditional diagnostic methods. WS provides this family with a theoretical foundation and help in reproductive genetic counseling and prenatal diagnosis. So, as we can see and as we can summarize, single gene analysis involves testing for mutations or alterations in a specific gene that is known to cause a particular disorder. This method is used when there is a high risk of specific genetic disorder in the family. And examples of single gene disorders we have already said is cystic fibrosis, sickle cell anemia, and Huntington disease. While whole gene analysis involves testing for the presence of large-scale genetic abnormalities across entire genome, this method can detect a wider range of genetic disorders and chromosomal abnormalities, including those that may not be detected by single gene analysis. Whole genome analysis is typically used when there is a higher risk of chromosomal abnormalities, such as in advanced maternal age or previous pregnancies with abnormalities. So, as we can summarize the whole issue. Previously, we only had karyotyping available to us. Then we have the CMA available. Now we have single test gene testing and the whole genome analysis available. So, time has come that we go into the details, try and avoid anomalous fetuses from being born, give a correct diagnosis and advice to the couples in their difficult situations and problems. And this science, as you can see, is going to go on having more and more implications in our everyday practice. And as I say, the tests are coming down because obviously multiple tests are being a need for multiple tests being recognized. And so let's hope that we will be able to, through these tests, help more and more couples to achieve a good outcome of their pregnancies. Thank you very much for your kind listening. And if there are any questions, I will reply to those right away.
Thank you so much, Dr. Gupte. Wonderful lecture and very informative, sir. I think you did take us through all the intricacies of the topic. So we do have a lot of questions, and in fact, I would like to tell you we have very high comments. People stating that these are very interesting, very much required topic of discussion. A lot of doctors have raised their questions. So let's take the question answers. So my first question is from Dr. Samira Aluri, who says, "Good morning. This may not be genetics related one, but NIPT, can it be used to know fetal BIGR and RH typing in case of RH negative pregnancies, in case of previous affected RH isoimmunized B?"
Yes, a very good question. Actually, there is a technique available, though it's rare. As far as I know, right now it is available, with couple of labs in Germany. I am not aware of any lab doing that in our country here.
Okay, sure, sir. Moving ahead, so my next question is from Dr. Virendra Prasad, who says, what is microarray technique used in prenatal testing?
I think we just went through, all these. I didn't want to go into the technical details of, how the test is done, because that's not for the clinicians. But I think, if we go through the slides once again, I think the details will be found there, or we can have a detailed discussions, some other time.
Sure, Dr. Dr. Pandey, I hope you got your answer. But in case you want to reach out to Dr. Gupte again and you want to know something in detail, we would be happy to help you.
In fact,
Sir,
welcome. Or anybody who is there, they're welcome to even visit our lab in city of Pune, and we can demonstrate how these tests are done. And this lab is called as a green array lab, and it's available. We welcome the research. We welcome demonstration through this. Learning also through this lab.
Sure, sir. Yeah, thank you so much. That would be really great. So, Dr. Pandey or anybody else who would want to visit or want to see more about the testing and how it is done, please feel free to drop by at Green Array in Pune, and we would be happy to help you for the same. So, moving ahead, Dr. Ajay Jain says, is not there urgent need to draw attention of policy and lawmakers about the seriousness of genetic testing and evaluation of genetic risk?
Yes, it's always, many times the tests come first and, laws come later on. Fortunately, there are guidelines, and one would follow is ACMG, or the American College of Genetic Testing. And those guidelines are very correct. There are Royal College guidelines, and there are, of course, American College guidelines also available. And in our country, of course, PCPNDT Act covers these guidelines. So definitely any lab which is doing it, has to make sure that, sex determination should never be, done for the sake of fetal termination and all that through this test. And we have to be very clear on that.
Okay, sure, sir. So my next question is from Dr. Rahul Zawar. I'm also sharing it across. So how to detect chondral dysplasia punctata? So if you would like to answer
that. Frankly, I'll need a help from my, genetic researcher to pinpoint exactly, because I'm also a clinician. So, pinpointing the genes will be definitely this thing. We can have maybe a webinar with them, and they will answer these questions. And again, as I said, welcome to reach out to me or my people at Green Array Labs.
Sure, sir. Yeah, I think that would be great, sir. I think we will definitely see if we can plan another maybe an interesting discussion with the researchers, and they would probably be able to help us better.
Sure.
Moving ahead, sir, what resources or support networks are available for patients who receive a prenatal diagnosis of a genetic disorder or a condition in India?
Yes, there are now, as far as I know, 7-8 good labs are available, and practically everywhere anybody wants to do this testing, the samples can be carried and taken to the lab. There are the sample needs to be carried in a particular container and particular medium that has to be there, and this can be done from anywhere across our country, and the test can be carried out. So I think little detailed research if they do. Again, I don't want to keep on saying that we will do it in our lab only. That's not ethical for me to say, because it's a conflict of interest. But if anybody is stuck, we can definitely help out in this.
Yeah. So one last question. So what are the ethical considerations? I think you did talk about them though, but what are the ethical considerations involved in prenatal screening and testing, and how should healthcare providers navigate through them?
Correct. So here the pre-test counseling is very important. I'll tell you the example of what happens, especially in a country like Israel, where in Jewish population, the Tay-Sachs disease, which is a very disabling disease, is very common, used to be very common because, their population has these mutations. So what they have done is to eliminate this, whenever a couple decides to marry, they are supposed to be carrying out these mutations. What they do is they don't reveal to the public, but when they go to their rabbi, he looks at these things also and just tells the couple that no, you're not compatible to marry. So not too much of a Allah made, and no discrimination, but at the same time, the message reaches that there is some harm. So we have some kind of method. In our country, thalassemia, is quite common. So we should be doing testing before that. But we have to be discreet. We have to be ethical in testing. Otherwise, so prenatal pre-testing counseling, pre-test counseling is very, very important, especially in this situation. And then the things can be made ethical. And of course, in our country, most important is these tests should never be used, for sex determination and discrimination. Otherwise, a good avenue that is open for us to wonderful diagnosis can easily be destroyed.
Correct. Thank you so much. Thank you so much, sir. No more questions ahead, sir, but if you would want to say something for your audience who are watching us live here, we have a mixed bag of surgeons, gynecologists, but also research enthusiasts and genetic counselors. So if anything for them, sir.
No, for all clinicians, researchers, I will say this thing, that this is the science of near future. The genetics, epigenetics, and next that is coming is the microbiome that we may talk about sometimes later. And these are, so every clinician now, every clinical researcher needs to know about these tests, these genetics, when to use these tests. And because in next 5-6 years, even the whole medicine, now already we know that cancer therapies are entirely based on the genetic mutations. How the patient will respond, to which drugs the patient will respond, entirely is based on. In fact, now oncologists cannot even start treating the patients without these testing being done in most of the situations. So this is the a science of future, but not too long a future. It's a science of near future, and everybody has to start learning about it and getting into it in details. There are various courses available, for this, online courses available. Even many universities are coming out with such courses. Again, as I said, we encourage people coming in learning it ourselves. We have associated with a couple of good universities for such courses too. So that work. Please get into this science. This is a new and very exciting science. That many puzzles as clinicians we had. We couldn't diagnose certain things. If there was a sudden fetal demise, we didn't know why it happened in more than 50% of the cases. So now we can at least give the cause, give the closure to the couple, and also the reassurance that next time maybe it can be avoided.
Can be avoided, can be taken care of if possible, can be managed. Yeah. Awesome. Thank you so much, Dr. Gupta. And I think once again, I would like to thank you on behalf of Doc Plexus and our entire audience for being here and talking to us on such an irrelevant and ever-trending issue here. We will be back with another clinical discussion for our audience again very, very soon. Dr. Gupta, we should plan such discussions more often. I think if anybody wants to reach out to you or the Green Array Lab, we would be happy to do so. And with this,
Darshika, through you and Doc Plexus, they're welcome with, whatever help I can give, I'll definitely.
Sure. So thank you so much. That makes a lot of sense. Thank you so much. And with this, we will close today's discussion. Thank you so much, Dr. Gupta, and thank you so much, dear audience, for tuning. Please take care. Have a good evening. Thank you. Bye-bye.